What did you say, doctor, the test was that you gave him? I gave him a latex fixation test. And is that a serologic test? Yes, it is a serologic test for the detection of the rheumatoid factor. And serum uric acid is a determination? Yes, it is. The abnormal increase in serum uric acid usually is indicative of gouty arthritis or gout. Doctor, synovial fluid studies reveal what? They reveal an examination of joint fluid to aid in the diagnostic and prognostic evaluation of joint disease by demonstrating the severity of the inflammatory process of synovial tissue. Doctor, is it true that in most cases the synovial fluid is obtained by aspirating the suprapatellar space of the knee joint? Yes, that is true, and the examination includes appearance and consistency of the joint fluid, culture of the synovial fluid to detect the presence of absence or of infective agent, cytology of the joint fluid, that is, red and white cell counts, differential count, identification of crystals such as urate crystals. Doctor, what is the measurement of calcium in this patient? The measurement is the method of Clark-Collip, which is a normal valuation of 9.5 to 11.0 milligrams per liter. Doctor, how much phosphorus is found? Well, a colorimeter method of Bodansky reveals 2.5 milligrams. And calcium? Calcium has the normal valuation, which is a decreased value in this patient. Doctor, let me ask you a few other questions about that. In 1877, Sir James Paget described the disorder or disease, which now bears his name, Paget's disease. He erroneously called it osteitis deformans, considering it a form of chronic inflammatory affection of the osseous tissue. Paget's disease has peculiar bone disorder with an insidious onset. It is followed by progressive disease and complications which may terminate life. In the skull, osteolytic, that is, osteoclastic activity predominates. A lesion of decalcification forms, particularly in the outer cranial table. It is termed osteoporosis circumscripta. Gradually, dense areas resembling tufts of cotton appear in the rarefied lesion, and the demarcation between them is the two cranial tables becomes indistinct. The patient's contour portrays the influence of pathological skeletal changes in advanced Paget's disease. His spine is kyphotic, stature shortened, position crunched or crouched, and abdomen pendulous. The anterolateral bowing of his legs results in a waddling, slow gait. The face appears small compared to the protruding skull, which characteristically shows bitemporal enlargement. Pain develops with progressive bone involvement and varies from a mild dull ache to intermittent or persistent ostealgia. Fractures occur frequently, heal readily, and are the most common complication of Paget's disease. They may be occasioned by trivial incidents such as tripping on stairs or turning in bed. The patient with Paget's disease, immobilized because of fracture or intercurrent disease, is likely to develop hypercalciuria, renal calculi, and hypercalcemia. Since bone repair is markedly decreased during immobilization, osteoporosis of disuse becomes a problematic issue. Bone destruction persists unabated, thus liberating an excessive amount of calcium which is spilled into urine instead of being deposited in bone.
That's fine.